So welcome all viewers, and today is World Organ Donation Day, and World Organ Donation Day is observed every year on August 13th to spread awareness about the importance of the organ donation and address and debunk myths related to the donation of organs. So this day we strive to encourage people to donate their healthy organs after death in order to save more lives. So donating organs like kidneys, heart, pancreas, eyes, lungs, etc. can help save the lives of those who are suffering from chronic illnesses. Numerous people lose their lives due to the unavailability of the healthy organs that could have saved them. This day aims to help people realize that volunteering to donate their organs after death can be life-changing for many. So I'm Dr. Rakesh Gupta. I'm president of Cypher and former director of services of Punjab, and my co-host is Professor Dr. Sonu Goyal. He's from School of Public Health, Department of Community Medicine, PGI Chandigarh, and we welcome you all for this special edition of Cypher Health News channel, coinciding with the World Organ Donation Day 2022. We feel honored to have with us an eminent public health expert, Dr. Jagdish Kaur, for an informal talk. So Dr. Sonu, you may please introduce, ma'am.
Yes, Dr. Madam Jagdish Kaur is currently a regional advisor at Tobacco Free Initiative at World Health Organization's regional office for Southeast Asia. Although she's a medical doctor, but over a period of time, she has worked in various public health, capacity, especially trained in global tobacco control from Johns Hopkins, Bloomberg School of Public Health, US, with an extensive experience of working in tobacco control and non-communicable disease in India and at the global level. Before she joined WHO, Madam Kaur worked at Ministry of Health, Government of India, where she has spearheaded development and implementation of various national health programs and has been a part of various high-level committees of the government. She steered publications of various documents, policy reports, modules, and various guidance material for the ministry and World Health Organization. Besides being implementing and had been a policy head, she had published various research papers in national and international journals, had a very long-standing experience in tobacco control and NCD surveillance at national and regional level. And in fact, when this National Tobacco Control Law, that is NTCP and COTPA, was initiated, so she had played an instrumental role from the Ministry of Health in spearheading that initiative.
So thank you, ma'am, and you're welcome to the Cypher Health News channel. Dr. Sonu Goyal, you can start with the questions.
Madam Kaur, thank you very much for coming here at this forum. And this forum, as I have told, as we discussed, this forum is for various public health people, those people who are youngsters and also who have achieved something. They also feel motivated seeing the talk of various eminent luminaries. And you have done exemplary work in various fields. Thank you very much for coming. Just want to initiate this, ma'am, that can you tell about your childhood days and about your initial career, that how you thought about working in tobacco control?
So thank you so much, Dr. Sonu, and in fact, Dr. Rakesh Gupta, for giving me this opportunity to, share my experiences, my motivation. So good morning, namaskar to all who are watching. So I come from a very humble background, not having any godmother, godfather in politics or bureaucracy. So it's a self-made career. And I've been a Delhiite, all through my education, and also the medical school in Delhi. Then I joined CGHS, Central Government Health Services in Delhi. So I practiced as a medical doctor in, Delhi only for almost 5 years. And before that, I had done my PG in ENT also, thinking that I should go into surgical field. But then, when I joined the service, I realized that, besides the clinical thing, you need very good people, uh, hardworking, committed people in the public health field, because that looks at the larger health of the nation. And because you draw policies, programs, and then, it goes into the actual health programs which we offer to people, at the ground level. So I was interested in doing the public health, and after 5 years you are allowed to do your, avail your study leave. So I joined MD in community health administration, because their requirement was 5 years of work experience at that time from National Institute of Health and Family Welfare. So we were a batch of 5 people there, and this was, very extensive experience in public health. And this course, it's quite different from the regular preventive and social medicine MDs, which we have also. So this gives you a larger perspective into health administration, management, and other matters. So we enjoyed, this course, and there was a lot of practical experience, field experience. In fact, I did my thesis with Dr. Helen Simon, who was director of the institute. She was outgoing that time, and I did my field work in Faridabad, So, and that was on healthcare of the elderly. And then it was another experience, when you do your thesis. So I finished in 99, my MD, and then again came back to CGHS. But then I had very focused vision, like I had to work with the DGHS ministry at the policy making level. So in fact, as soon as I came back, I used to tell people, I'm here for a few days and I have to go. And that time I had nothing in hand, nobody was calling. But I had that thing, no, I have to go. I'm not here, to do the clinical work. So then there was a call from DGHS, Dr. SP Agrawal was there, and they wanted, more people. Because always the Directorate General of Health Services, it had the limitation of having very few people, very few positions and all. But then DG wanted some more people, and they called people for interview. So I went there. So myself and one of the colleagues, we got selected after that, because they were looking at, your liabilities, if you are able to spend long hours. But I was kind of a little perturbed to see that people, who do public health, I mean, it is there to make a career. I mean, you just don't do any MD. I mean, any post graduation, you spend 3 years, and then you have to have a vision, whether it is public health or any other MD. But then people, they just do their MD, and they, they are not willing to contribute at the national level, saying that, these are very long hours. You have to be there in the office, past your normal time, which is 5:30, but then there's no time there. And then there were all kinds of excuses. But anyway, because I was willing, so I was very happy that I got selected. And then I was given to handle so many programs, other things. And at that time, I had no experience of handling office and this kind of work, because I came from clinical background. But for doctors, there is no such training. Like, there has to be some induction training, which also, we explored at a later stage, but it didn't materialize because they just come from clinical background and they have to handle these things. And then this is, learning by observation, on the job training and other things, where you really have to, work and see. But then if you are interested, if you have passion and commitment, then, nothing stops you. And when I joined, and then we actually, started many public health programs, and I'm very proud of that. That so many things just started that time, and they were implemented and still going on. So that's a little background, Dr. Sonu, which I thought I should be sharing.
Yeah, excellent, ma'am. I think as you have told that you have started with a very modest journey, and at that point of time, I think not many of them are so motivated to work in public health. And you started your this thing, you joined community health administration, and then you were having that zeal in public health. So I think young people who are listening to it might get that idea that if you have a zeal with you and you work towards that direction, so nothing is impossible. So thank you very much, ma'am. And over to Dr. Rakesh.
So, ma'am, you have been in tobacco control since long, actually, since 2007, as you told us just now. And so that's a long time working in a program. And what do you think are the immediate tasks at hand for India to reduce the tobacco burden?
So yeah, I have been there, for a long time. I had the privilege to work with the Directorate General of Health Services, and then also, Ministry of Health, looking at the program and the law from very close angles for a long time. And at that time when the country was struggling, with implementing the law, because it industry took us to the court, and finally it had to come out of various court cases slowly, and the things were implemented. So now, I mean, it has a long time because the law came and 2003 COTPA, then we ratified the FCTC 2004, and then the, smoke-free policies, then graphic health warnings and other things, then country established the tobacco testing labs. So much has been done, then national quit line, other things, on various aspects of tobacco control. And now we are also talking about, lately end game tobacco. But if we look at, from GATS 1, which we implemented in 2009-10, then GATS 2, 16-17, and now in the process of GATS 3, there is preparation going on, in the ministry for implementing GATS 3. So there has been a decline, in tobacco use prevalence, but it's not that much, which I feel, that we are near to the end game, because there is so much to do. There are so many new challenges, which come every day. So because industry is too smart, I mean, we went for smokeless tobacco ban, but we know that, it's available in different forms. And then we are not able to enforce the bans. The advantage is that we have all the things which are available for tobacco control, like we have the law, we have FCTC, we have best buys, we have everything, we have other provisions which I just mentioned, but we need to enforce. So the enforcement, I think it lacks. It has to be kind of a little more done in a very committed and serious way. And because it's a central law being implemented at the subnational level by states, so everyone has to understand, tobacco, and because it's a risk factor for non-communicable diseases, and when 60 to 70% of people are dying of non-communicable diseases, and tobacco being a major risk factor, we need to look at the risk factor seriously and then implement. And we know in our country, smokeless tobacco, oral cancer, other diseases which it is causing, and young people dying. So
Right.
we need to be more serious in enforcing the policies. And also, I think tobacco control, it goes here with the behavior change of the population, and that takes long. So because if you are consuming smokeless tobacco, areca nut, all these things, various forms of smoking, which is kind of, we have bidi, hookah, and now with this shisha smoking so popular among youngsters. So these kinds of things, so many products, different kinds of consumption, different kinds of behavior. So that's a big challenge. So I think we need consistent program implementation at the subnational level and monitoring that, and just see, like where we stand. Do we need to modify the policies? Do we need, midterm corrections, or we need some more efforts into a particular field? So I think that kind of issues are there, which we need to seriously look into, and then deal with the challenge of industry interference, because Article 5.3, I think that needs also to be kind of guidelines need to be implemented at the ground level very seriously. So this is what I feel, Dr. Gupta.
So, ma'am, I totally agree with you because of the stalwarts like you, the leadership provided by you people. So we have done a lot. Actually, India has done a lot in the field of graphic warnings. And as you said, the GATS 1 and GATS 2 survey also shows some decrease in the prevalence. But I agree that the implementation of the law is very, flimsy in most of the parts of the India. And it all depends upon the implementers. because people now know about the ill effects of the tobacco. There's no doubt about that. Awareness is a lot. So the only lacking thing is implementation. And I think the cessation that also needs to be upgraded at all levels. I mean, at the government medical college levels, at the district hospital level, so at all levels. And all the doctors, I think they need to be motivating their patients for tobacco cessation. So thanks, ma'am. Yeah, over to Dr. Sonu.
Yes, ma'am. As you have told, ma'am, there are various challenges despite a lot of work has been done in India. India has been a pioneer since your tenure. India has done a lot of things like that big graphical warning, where India stood very high in terms of countries. Banning of electronic cigarette has been there, and a lot of other things which India has done. And even in the Framework Convention on Tobacco Control, I think India has played a very leadership role in FCTC. So just want to know about you, ma'am, that what are the things which we are right now thinking from, because India is playing a very stellar role in Framework Convention on Tobacco Control. So what are the things which FCTC is thinking in illicit tobacco product things which are coming right now?
So I think this is a very good question, because we need to see, like whatever been our commitments, what we are doing. So India is a party to the protocol, which is, Article 15 of the convention, FCTC. So India ratified that we have two parties to the protocol in the region, Southeast Asia region, which I handle. So first was Sri Lanka and then India. So after that, India, they developed the framework, to implement the protocol. But I think because within 5 years of the protocol ratification, you have to establish track and trace mechanism. So there is that gap, and we need to, because that is basically also, it caters more to the cigarettes, because track and trace is simpler with that as compared to the other products, because there is so much of variety of products there. So that is a challenge, which we face, and that is the thing which we have to do in a timely manner and kind of implement that. So we know that, how this illicit trade is happening, where it is happening. And because the countries which are around us, with whom we share our large porous borders, they always complain that illicit trade, with India is happening, because India is a large producer. We are a big manufacturer of many tobacco products. So most of the small countries who are not manufacturing themselves, who are only importing, I mean, from there it comes, in a legal way or an illegal way. So we need to have a look at the illegal way. And then the studies on this, the actual data on that is also lacking. How much of the part is actual illicit trade? So there have been a couple of studies, but I think we need to do more in that. And also I would like to add for graphic health warnings, we are proud that we have 85%, we have big graphic health warnings on tobacco packs. But if we look at some of the packs, I mean, they are revising the warnings, rotating from 1st of December, I think now again with the with very, I think, strong messages, text warnings also. But we need to see, that these warnings are getting implemented as they have been prescribed. So there is a big gap. I mean, we have the studies available, we have the evidence where, it is very clear that the warnings are not, depicted on the tobacco products the way they are being prescribed. So especially other products, especially the BD, especially the smokeless tobacco packs. So there you don't make out, like it has to be a very clear picture if you actually want to give the message. But if that picture is not being depicted, in a clear way, then it kind of undermines the entire effort. For this. So there has to be not just, you just say that, okay, this is a warning, you just kind of implement, and then the industry says, okay, we have done it. But who has to monitor? Who has to see that it is being done, properly? So these are the things which, I'm again and again flagging, that once we have the policies in place, laws in place, you have to monitor that they are being implemented as you are prescribing. And there are enforcement agencies, and we have to repeatedly train them. First time when the law came, COTPA. So we train people. We had a national workshop, we had regional workshops, we had state level workshops. So we used to call all the stakeholders who are there, law enforcers. And that time was the beginning. I mean, they used to ask, why are you calling us? What is our role in tobacco control? It is a health matter. But tobacco is mostly out of the health sector. So we explained, and there were people who were then got enthusiastic, and like it has to be mainstream. In fact, the enforcement has to be mainstream with police, with drug inspectors, food inspectors, whoever are there, to enforce these laws. So that needs to be continuously done. Not that it is done and then forgotten, and then after years you revive. So I think because people change, they go from their respective jobs, and then we have a new set of people which need to be again told. So these are the things, because otherwise then the law, it becomes kind of, it's not implemented. So you have to tell people that this is the law, this is the provision under the law. Because I can give you an example, because I was handling mental health in India for a long time. So we had a mental health act, and that was 1980, and then the rules came after a long time, and nobody knew. And every police station, they will refer to 1912 Lunacy Act, the British time. They don't know that we have a mental health act because we never told them. We never had any trainings. So then we in fact had to come out with a new law, Mental Health Care Act. So these are the things. So once you have a new legislation, it is always good to, and then there are changes in the law, then there are amendments, then there are different rules, which are coming. So every time you need to tell people that these are the provisions. You are an enforcement person, and this is how, this is what your role is. So these things really help.
Right. So, yeah, ma'am. So thank you, ma'am. From your perspective, just want to know, because many young people are listening to this talk, including public health specialists, and some people are really wanted to work in tobacco control. And over a period of time, many people have come from various medical colleges and institute who want to work in tobacco control. So what is your perspective to involve them? How we can involve them? How WHO can involve? How we can involve people across country so that they work toward tobacco control?
I think there can nothing be more relevant this questions, Dr. Sono. See, because when I was there in the directorate, and before that, Dr. Prasad was there, he was the director handling, and I was the CMO. There were 8-10 people in the entire country who were custodians of tobacco control.
Right.
Yeah.
And in fact, I think they were not letting other people, come and join.
Right.
And we were the people who actually opened it to public. Okay, anyone who wants to do tobacco control. We trained people, like I said, used to call hundreds of people to these training workshops, and then I used to request my academician colleagues, the professors in the medical college, please ask your students to take up their thesis on
Right.
tobacco. So
Yeah,
now
yeah.
many have done, and many people have done, and then the creation of these laboratories, and then getting other people also, because I was handling many programs at that time. So, like addiction, I used to talk to mental health colleagues. I used to talk to my this aging program colleagues. So anyone who's doing anything, oral health. So we try to integrate, the horizontal integrations with other programs, getting more and more people writing letters all the time, writing mails, sending letters to medical colleges, sending letters to dental colleges. So every time, you just disseminate it and get more people to work with you. So these are the things, like you have the resource center. You are in a good position to, ask, join, people, motivate people to join hands for tobacco control. So these are the things, you just use your position, just use your networks, just use your partners to get more and more people into tobacco control, because it's everybody's business. It's not like, I just heard that we are having, there is a process going on for establishing tobacco cessation clinics in the medical colleges. So, earlier they had for the dental colleges. So it's not a rocket science, to have a TCC. Anyone,
Right.
so many TV people, I asked them, and they established TCC. This Maroli hospital, they established a TCC. So it's not this big thing, but the thing is, because tobacco, it ultimately causes the disease after a long time. And people say we don't have anything, I mean, I'm not sick. Why should I go to a hospital or a clinic? And at one point of time, many of these, they were in psychiatric hospital or cancer hospital or these kinds of setups. So anyone who's not having any issue will not go. I just want to quit. I'm a tobacco user, so I should be given that facility as per my convenience. So it can be a quit line, I should be able to call as per convenience, but sorry, because see, all these quit lines, they failed to address to the people who are calling, especially during the COVID. They were overloaded. They didn't have that many counselors. And then you are putting that number on all the tobacco packs, and when people are calling, there is no response. So that's not a good thing. They should have seen. And then there is M cessation, which just give a missed call and they'll get back to you. That should have been promoted. There's no promotion because when we launched, there were more than 2 million users who got registered. It got stalled after that. So the ministry is not kind of using that. And then we launched a WHO with tobacco app earlier this year. That should be promoted. That is so easy. It's for Android and iOS both versions. So you just download on your phone and use it. So these are the things, which I mean, these are the tools, these are the facilities which we have, and all these. And then we also have Florence, we have chatbot, and WHO has so many other avenues, which are available on the website. Those can also be used. So it should be the convenience of the user. Then only that person will be interested. Otherwise, if we ask him to go to a medical colleges, which is 50 or 100 kilometers or whatever from his home, I mean, that is only useful for the people who are visiting that hospital. So that's fine to other departments. And that also we have to request our colleagues in all the departments to kind of send the tobacco users there. We have to sensitize them. And same as with the dental college. So, but if we have all these things, the quit line, it should be properly equipped. If we have M cessation, then person, can get registered and get the messages on the phone, then can get help, and then get, I mean, role of health professionals we just spoke. That's very important. First is all health professionals, asking about tobacco use. That's the basic. So these are the TV programs. So India is doing TV tobacco integration and TV program as well established, from the national level down to the PHC. So that can be used. So these are the things, we must be looking at, just kind of going out of box, not standalone tobacco, but how we can mainstream with other things. And in fact, at one point of time, I used to say that you don't need any money for tobacco control.
Right.
You just need a pen.
Right.
So, I mean, people have to be enthusiastic and committed and motivated, to do their job. If you just do it in your normal way, okay, I come to office, this is I have seen this month, files are going home. It will not. I mean, not only tobacco, nothing will be done. So, I mean, you have to have that zeal. I mean, somebody was telling me the other day that now, it's not that much of zeal in the ministry. It used to be earlier, people were interested. But I think you need regular motivation, you need regular trainings, you need, I mean, it should be an ongoing process.
Right. So I think very well said, ma'am. I think the person, those who are young, so they should have a vision for tobacco-free India, and they should be committed and have a zeal for doing that. Positive attitude is must. They should not think that tobacco is still a problem. They should see that a lot of things has already been done. We just need to promote that. Hard work is really required, as you have done in your entire life. You have narrated from your story the hard work which you are still doing after a period of 20-25 years being in tobacco control and thinking out of the box. And I think these are some of the characteristics which young people listening to your story might have felt, and these are the things which are really required by them to pursue tobacco control in their career. Dr. Rakesh?
Yeah, I think before we get a message regarding the National Organ Donation Day, so I'll just like to tell that since you know that we had a project from WHO, a short project, but on the basis of the compliance study of almost 700 plus points of sale. So our interns, they have submitted 7 studies, and hopefully 4 or 5 will be selected for publication. So that is all because of the encouragement from WHO, from you. And ma'am, now I think we have to, conclude this interview. So we will like to have a message from you regarding the regarding actually it is World Organ Donation Day. So what is your message?
So, Dr. Gupta, for the organ donation day, because see, this is a very, very important cause, and so many people lose their lives because they don't get the organs, in time. So first is that all of us need to pledge for organ donation. Second is that people should be sensitized. So many times people pledge, but then later on the relatives, they don't agree and they don't give that. So that kind of sensitization should also be there, that it is a very important cause and we are, contributing to that. And whatever are the myths attached with that, we need to, break those myths. Then is that it has to be done timely. Like if your cornea is to be retrieved, it has to be done, within a few hours, because after that it's of no use, and other organ also. So it has to be very good coordination, because I have seen when all these laws were being kind of amended, and because earlier the law was itself an issue, because people were not able to, give, and then Orbo and other organizations. So I think this networking, sensitization, and the role of health professionals to sensitize people, to relatives, that is very important, because and that to be done in a very timely manner. So I think we all have to work towards that, and this will only happen when we all work towards the cause of donation.
Yeah.
So that is what I feel.
And ma'am, you'll be pleased to know that since I'm an ophthalmologist, and we have in Punjab, we did a lot for cornea donation, not organ donation as such, but we have been promoting cornea donation. And because of the efforts of Punjab government, now the driving license form that has got this column, whether you want to donate the organs or not. So thanks, ma'am. Thanks a lot, ma'am, and for sparing your time. And Dr. Sonu, you can conclude the interview. Yeah.
So thank you, Madam Kaur, for sparing your valuable time. I know that it's quite a busy office. You have been working a lot, and a lot of challenges are there, but how to convert challenges into opportunities. So we have learned from you hard work, commitment, and dedication towards a cause. So if we got a message from you through your entire life journey, that if you work quite hard, if you have a vision in your life, you can do a lot of things. So thank you, ma'am, for coming here, sparing your time, and looking forward to interacting with you again.
Thank you so much.
Namaskar.
Once again.
Thank you, ma'am. Thank you. Thanks a lot. Thank you. Bye. Bye.
Hello and welcome to DocFlex's Health Minute. The state government of Rajasthan has revised the duration of mandatory service for doctors, shortening it to 2 years from 5 years. The rule is in place for students completing post-graduation and super specialties from government medical colleges. The European Medicine Agency has recommended a renowned American COVID-19 vaccine manufacturer to carry a warning for heart side effects on its COVID shots. The agency has asked to list 2 heart side effects, including myocarditis and pericarditis, as a part of the product information. Researchers at the University of Bristol have developed mathematical models to determine the current use of biomarkers in glioblastoma detection and how the biomarker-based strategies could be improved further. The study is associated with the University of Bristol-led CRUK project for developing an affordable blood test for diagnosing brain tumors. According to a study published in The Lancet, the infectious monkeypox virus can persist in semen weeks after recovery. Health officials have maintained that monkeypox is not a sexually transmitted disease. However, whether it can be sexually transmitted via genital fluids is still under investigation. An expert committee set by the Health Ministry India has recommended banning codeine-based cough syrups after concerns were raised in the Parliament about their misuse as narcotics and intoxicants. What are the best ways to curb the irrational use of codeine-based cough syrups? Share your views by commenting below. For the latest medical updates from across the globe, stay tuned to DocFlex's Health Minute. Happy DocFlexing!